So next is infections following transplantation. V7. A 40-year-old male presents to transplant clinic with a short history of fever, night sweats, arthralgia, and anorexia. He is 5 months following deceased donor renal transplantation. His immunosuppressive regime is mycophenolate, mofetil, and tacrolimus. Blood tests show a slightly raised creatinine with leukopenia and mild transaminase raise. How will you manage this patient? I will review the history to identify signs and symptoms of common infections and then examine the patient. In addition to UNEs, LFTs, FBC therapy, I will request screening for viral infection like cytomegalovirus, Epstein-Barr virus, and BKJC, and also check the drug tacrolimus levels, and also check the donor and recipient cytomegalovirus status at the time of transplantation, and ascertain both the presence or duration of cytomegalovirus prophylaxis treatment. Send blood and urine for culture and request a chest X-ray and ultrasound scan of the transplant kidney. The tacrolimus levels are 14. And CMV PCR is positive. Log therapy. How will you manage this patient? So this patient has symptomatic cytomegalovirus viremia. Antiviral therapy with oral valganciclovir or IV gencyclovir is the mainstay of treatment. Treatment is usually for 2 weeks or until CMV PCR is negative. This tissue invasive disease may require 4 to 6 weeks of therapy. Following treatment, I would continue with serial CMV monitoring for disease reactivation. As his tacrolimus levels are high, I would reduce tacrolimus dosage and monitor closely for any further relapses of infection. Over-immunosuppression often present with intercurrent infection. What do you know about cytomegalovirus prophylaxis in transplant patients? The simplest strategy is to offer the prophylaxis to all high-risk patients. All CMV negative patients receiving organ from a CMV positive donor, patients receiving T cell depleting antibodies as an induction agent if either the donor or the recipient is CMV positive. Valganciclovir is the most common antiviral in the use of CMV prophylaxis. Treatment is recommended commenced within 10 days of transplantation. The dose is titrated according to the patient's creatinine clearance. Prophylaxis is currently recommended for 100 days in most cases. What are the modes of CMV infection in transplant patient and when does it usually occur? Transplant patient develop CMV in several ways. Transmission of virus from the donor organ, primary infection of non-immune CMV recipient, superinfection with the different CMV strain, reactivation of a latent infection. CMV infections typically occur between 1 and 6 months after operation during transplantation during the period of maximal immunosuppression. Infection within the first months are generally nosocomial and related to the transplant surgery. After 6 to 12 months, the infections are usually caused by conventional community pathogens. How does CMV affect the transplant recipient? Direct effects and indirect. Direct effects: CMV infection may occur. CMV disease may occur symptomatic viremia, tissue invasive disease, gastrointestinal pneumonitis. GIT involves pneumonitis, chorioretinitis, and graft dysfunction. Indirect effects: immunosuppression. CMV infection suppresses the both T cell and B cell mediated immunity, leading to superimposed opportunistic infection. Acute rejection: despite enhancing immunosuppression, CMV also increases HLA class 1 and 2 expression within the organ terminal, leading to increased acute rejection. Long-term CMV infection has been associated with the development of allograft vasculopathy and new onset diabetes after transplantation. Thank you.